Yeah, so I think this is a good segue into how do we categorize a hormone sensitive and a hormone resistant disease. So, I'm just going to go over the brief definition, but I would love to hear you guys in your clinical setting. How do you differentiate these people? Hormone sensitive prostate cancer, the way I think of it is, if your disease is still responding to testosterone that we can detect, that's what we call as hormone sensitive disease. And hormone resistant disease is when you have a testosterone level that's below 50. And, typically these patients are quote unquote more aggressive, and have a poorer prognosis than patients who are castration sensitive. And one of the key things I wanted to sort of ask you guys as well, patients might have this question, oh, if it is a hormone or or castration sensitive disease and a castration resistant disease, do I still need to have those shots? So
Yes.
if you can go over both these things, that would be great.
Yes, definitely. I can start with that. I think it's a very common question. I think, when you have someone, that eventually doesn't end up responding or becomes that hormone resistant prostate cancer, the question becomes, why should I continue doing these hormone injections potentially? When I discuss, prostate cancer in stage 4 setting like this, I sort of explain that testosterone is sort of the food source, and we're cutting out the food source initially in the hormone sensitive setting, but sometimes and eventually the prostate cancer will find its way around, just depending on testosterone by itself. And so, I say, a couple things, I guess, with this is that, there are still some cancer cells, prostate cancers, that are still responding to the hormone injection. So I think that's an important point to, say is that, although, some of the cancer is not responding, there are still parts of the cancer that may still be respond to the hormone injections. So I think that's one thing. And then I think, a lot of the times, when the clinical trials designed around this have really included patients, still with the hormone injections moving forward, even after they quote unquote are hormone resistant or stop responding to the hormone injections. That's the way we've studied prostate cancer in that setting, just because we know there is some benefit. And there are something that we call clones, or, parts of the cancer that, may not respond as well to stopping the testosterone production as a result of that.
Dr. Tawagi, do you have any other pearls on how you counsel your patients or how you describe this to your patients?
Yeah, I think, I tell a lot of men that may not even be familiar with what testosterone is, that it's the primary male hormone and that's the fuel for the cancer. And I think similar to what Dr. Kurian said, we try to remove that fuel initially by giving these hormone shots, which lower that male hormone, the testosterone. But then cancer is smart. Eventually, it figures out ways to grow around that fuel source. And so we have to target it from different ways. But to Dr. Kurian's points, there's still a population of cancer cells that might still be responding to removing that male testosterone. So we usually continue the hormone shots and then we add something else on top of it.
Yeah. Yeah, no, definitely. And it's important to realize that this was sort of the seminal way of how we found out other drugs that we now have in our arsenal, that we sort of target other ways to treat prostate cancer. And we'll go into some of those details as well.